Hello, everyone. I think we are ready to get started here. I hope everyone can hear me properly. And if you can hear me, please type yes in the chat box, which is to the left side of your screen. Great, so I can see some yeses already. Welcome to Asthma Canada's Speaker Series webinar. Our 2018 webinar series has been made possible through educational grants from AstraZeneca, GSK, and Novartis. This is the fourth in the series, and the topic today is phenotypes of asthma. Thank you for joining us. My name is Manaz Rahman, and I'm the Manager of Programs and Services at Asthma Canada, and I'll be your moderator today. Please note that the webinar will be recorded and made available on our website and YouTube channel. All attendees are muted. If you have any questions, please type them into the chat box, which we will be monitoring throughout the session. There will be a question and answer period after the presentation has ended, and our speaker will try to get to the questions at that time. Now, very quickly, before we begin, I would like to highlight some of the work we do here. Asthma Canada is the only national organization solely dedicated to helping all Canadians affected by asthma. We are committed to improving the lives of the Canadian asthma community through education, support services, research, and advocacy. We provide education and support to those living with asthma and their families and communities, both in print and online. We offer free services like our Asthma and Allergy Helpline, which gives all Canadians access to certified respiratory educators, and run an asthma and allergy-friendly certification program, which provides a comprehensive list of certified products, consumer tips, tools, and downloadable materials to ensure a home environment suitable for people living with asthma and allergies. We advocate to the Canadian government on improving health outcomes for people with asthma. Our current priorities include clean air, clean energy, and equitable access to medications and treatment options across the country. You can learn more on our website and join us by participating in our active letter writing campaign to government representatives. We support research for improved treatment options and to find a cure for asthma. Last year, we initiated a new addition to our national research program to provide grants to emerging asthma researchers in partnership with Allergen NCE. And in fact, we will be announcing the winners of the 2018 awards this fall. Additionally, much of the work we do is with our volunteers and members across the country, people living with asthma, their families, parents, caregivers, communities, healthcare providers, educators, and others who are committed to improving asthma care. The Asthma Canada Member Alliance, or ACMA, is a free membership of Canadians who engage in the work we do and who provide valuable input on our initiatives. If you aren't yet a member, we encourage you to join us by visiting www.asthma.ca/join. Please visit our website for more information and feel free to get in touch with me at any time. And now I'd like to introduce our distinguished speaker for today, Dr. Patrick Mitchell. Dr. Mitchell joined the University of Calgary's respiratory team in July 2016. He trained as a specialist in respiratory and internal medicine in Ireland and undertook a 2-year clinical and research fellowship at McMaster University under Professor Paul O'Byrne. This encompassed translational research in airway inflammation and servicing both general respiratory and airway inflammation clinics. Dr. Mitchell also completed a 2-year medical doctorate thesis on the role of IL-33 in allergic asthma. He's been appointed director of the Asthma and COPD program at the Rogby Hospital in Calgary. He's authored numerous peer-reviewed research manuscripts and co-authored a book chapter on asthma, and his clinical interests include asthma, COPD, chronic eosinophilic airway disease, autoimmune pulmonary diseases, and airway disease in pregnancy. So with that, let's begin. You can take over whenever you are ready, Dr. Mitchell.
Well, thank you very much for that kind introduction, and thank you everybody for tuning in today to listen to this talk on what is a somewhat rather complicated topic to discuss, asthma phenotypes. And indeed, I should start off by saying I have very little idea about what asthma phenotypes are. So it is new and it is coming up, but it is absolutely important. That's what we're here to discuss today. So again, thank you for that introduction. So just to move along to my conflicts, there you are. So just grant support, research support, speakers honoraria, and consulting fees. So This is the last known picture taking of the Titanic before its maiden voyage, before it struck an iceberg in the early hours of April 15th, 1912, losing 1,500 people. What's significant about this? Unfortunately, about that number of people die each day worldwide from asthma attacks. So asthma represents a severe and significant burden of health. Indeed, it is felt that asthma and chronic asthma accounts for the top 2 to 3 places of burden of medicine in chronic diseases in Western countries, and it's growing. Approximately 400 million people worldwide have a diagnosis of asthma. That's an enormous number of people when you think about it. That's larger than the combined populations of the United States of America and Canada. Approximately 18 to 19 billion euros is spent each year in the European Union in the treatment and economic loss from asthma. In Canada, we spend approximately 2.7 billion Canadian dollars in the treatment and management of asthma each year. Asthma is a chronic and debilitating disease, but it's a disease that gets slightly mislabeled. And it's a disease which traditionally we have treated as one cap fits all asthmatics. And as we know, hence the reason for this talk today, we need to move away and have a paradigm shift in regards to treating that thought process. So just to bring you on, what are we going to talk about? First things are assumptions. I'm going to make a few assumptions so people know what asthma is per se. I'm going to talk about what we know about asthma phenotypes. And again, just to reiterate, this is a changing field. As we learn more and more and more, we change these definitions. It's not trying to confuse people, it's just trying to keep up with the science. How do you know what type of asthma you have? How can our knowledge of asthma phenotypes be used in treating asthma and severe asthma? And what's new in the field of asthma phenotype research, and why is it relevant? So assumptions is that you have a diagnosis of asthma, and we're comfortable that you do have asthma. I run a severe asthma clinic on a Monday or a Wednesday afternoon, and the first question I ask myself is, does this patient actually have asthma? It's really important to get that diagnosis right, so you're not treating a different disease with different medications, etc. That there's an understanding that 3 groups of inhaled medications, namely these beta agonists, anticholinergics, and of course the backbone of asthma treatment, inhaled corticosteroids, are established in patients. And a basic knowledge of CTS and GINA guidelines in treating asthma and how to manage your asthma. So what is a phenotype? Well, a phenotype essentially is a set of observable properties of an organism that are produced by interactions between its genotype and its environment. Or worded another way, patients with common characteristics are grouped together in an attempt to guide therapy and management. Now, why is that relevant in respect of asthma? Well, as I mentioned earlier on, the label of asthma is given to 400 million people worldwide. To me, that's like telling 400 million people they have cancer and not telling them what type of cancer they have. It's really important to get personal and to get precise. The other definition and wording that you will read about, especially those of you who are in the healthcare ambit and those of you who are really interested in finding out, well, what is this whole thing about asthma? What is the science that's going on here? Is something called endotyping. An endotype is a specific biological pathway that has been identified that can explain the observable properties of a phenotype. So pertaining to asthma, it's defining subgroup by specific cells or molecular pathways in blood, in sputum, in bone marrow, in bronchial epithelium, so in lung tissue. Again, what we're trying to do is trying to get specific to try and tease out the different pathways that might be causing asthma symptoms in one patient as opposed to another. So to try and rationalize what I'm talking about, I've introduced this weird graphic here where we have essentially computer languages. Now, In doing this PowerPoint presentation, I used PowerPoint. But PowerPoint required another platform of a software program upon which to deliver itself upon. And that software program required an assembly language. And beneath that assembly language is machine code and binary code. Up here is what we see out in the street and in our clinics, the Word documents, the PowerPoints. Here is where we get our tests, our blood tests, our chest x-rays, our lung function testing. And here is probably where we are in the laboratories, where people are doing their PhDs, trying to tease out these complicated pathways to try and really understand what makes one person's asthma responsive to a very low dose of an inhaled corticosteroid and another person require heavy-duty biologic medications, such as the new anti-IL-5s. Again, this is just trying to stratify this asthma syndrome. And indeed, there is a slight paradigm shift into calling asthma a syndrome, a constellation of shared symptoms by patients complaining of episodic wheeze, breathlessness, mucus production, waking up at night. Moving it down to phenotypes, saying, well, there are triggers for these patients, triggers for those patients, and then endotypes, trying to find out, well, what is the distinct pathophysiological mechanism at play that causes X to respond to dust mite and Y to have absolutely no history of atopy or allergy. The reality in our clinics in regards to phenotyping and endotyping is we live here in this Venn diagram. We try our best to do both. So down here we have the hay fever, allergic, atopic, asthmatic. Up here we have the bronchial biopsies where we're doing intrinsic work looking at different cellular patterns which may help us in target specific treatments. So why do we bother characterizing asthma? The reason why is it's no longer fair when so I'm just looking at messages here coming through. I'll use the mouse a bit more, apologies. Why do we bother characterizing asthma? It's no longer appropriate to define asthma as a symptom which applies to every single person with the diagnosis. One, asthma is a symptom of differing airway pathologies. And the more we look at this and the more research we do, the more we realize this is absolutely valid. Patients with long-standing severe asthma redefine normal. Many patients with severe asthma have clearly defined atopic histories, where others give little indication of an allergic component. Now, what do I mean by this? I see patients who come in, absolutely no triggers, who are skin prick negative, who have normal IgE levels, who have normal blood eosinophil levels, who have severe asthma, who are unresponsive or poorly responsive to high-dose inhaled corticosteroid medications, oral therapies, and are frequently requiring oral prednisone. And I see others who are severely atopic, who do have positive skin prick tests, who respond when put on appropriate medications exquisitely well. There is a difference between these patients, and we know this is this uniform lack of a response to particular medication classes. Molecular pathways have different and now clinically recognizable phenotypes, which we can target in a certain subgroup of severe asthmatic patients very efficaciously. Interrogating asthma phenotypes will and has translated into improved understanding of asthma pathophysiology and has actually allowed us to select appropriate medications for select patients with drastically improved outcomes. And it's now being internationally recognized by guidelines such as GINA, which is, as you all know, an international consortium of experts in the field of asthma who now advise on attempting to phenotype or to precisely identify what type of asthma a patient has. Just to mention two large programs, the SARP and the UBioPed. These are very large programs, multi-centered, looking at very many patients, thousands of patients with asthma, in an attempt to try and learn more about their response to treatments, their lack of response to treatments, their symptoms, and biomarkers to try and establish better biomarking and predictors of responses. This SARP project, which is in the United States and that's continually ongoing, has identified 5 phenotypical clusters of asthma. Cluster 1, early onset atopic asthma. Clinical features, atopic, i.e. allergic, usually have an eosinophilic presence, i.e. in sputum, or an elevated FeNO, which is nitric oxide that you exhale, and usually are quite responsive to very responsive to low doses or medium doses of inhaled corticosteroids, a long-acting beta agonist, which is essentially long-acting Ventolin or Bricanyl, and a leukotriene receptor antagonist, Singulair or Montelukast. Cluster 2, early onset atopic asthma. This tends to be the largest cluster. These usually have an atopic disposition, eosinophilic inflammation, and usually are older, i.e. probably above the age of 12, and are trickier patients, as I see in my transition clinic that I run. Half the issue there is a compliance issue, but half the issue is that they tend just for some reasons to not be just as sensitive to the effects of an inhaled corticosteroid. Cluster 3 is late onset asthma. They're less likely to be atopic, and they're mostly older, overweight. They usually have decreased lung function, but this is likely to be secondary to the effects of their weight. Weight control has been shown to be probably the biggest predictor in beneficial responses to treatment. The lighter you are, the more responsive you are to inhaled corticotherapies. We also know these women are likely to be postmenopausal, so there may well be a hormonal influence. And they are a group that I am seeing increasingly in my clinic, and they are difficult to control. Cluster 4, early onset atopic asthma with severe asthma symptoms. This cluster shares an awful lot of similarities with cluster 1, but they're usually in their 20s or 30s. They've eosinophilic inflammation, increased sputum blood eosinophil counts, and increased phenos in places that do them. These patients require high-dose treatments, high-dose inhaled corticosteroids. They're frequent exacerbators, and frequently these patients are in need of advanced biological treatments, such as the anti-IgEs and the anti-IL-5s. Omalizumab, benralizumab, mepolizumab, relizumab. Cluster 5, late onset atopic severe asthma, less responsive to bronchodilators. Interestingly, in this group, although the clinical features do mention eosinophilic inflammation, another cohort, which I will mention later on, is this cohort of what we call neutrophilic asthma. Now, neutrophilic asthma silences half a room of asthma experts and excites the other half. Some people think that it is essentially a contaminant or a response to high-dose inhaled corticosteroids. Other people think that it's a real phenomenon. There has been a clinical trial which targeted eosinophils within the airways. And whilst it radically decreased the numbers of neutrophils within the airways, this reduction in neutrophil count was not clinically significant, which had the naysayers of this phenotype of neutrophilic asthma say, haha, this doesn't really exist, but it's a bystander. But this is yet to be fully established. I've gone through these phenotypes. I won't go through them in any more detail. I'll just mention a couple of things as I do. In this adult onset atopic asthma, about 30% of these patients appear to respond to Xolair or omalizumab. And we don't know why 70% of them don't. The other onset, or the other subset of asthmatics that I'd like to talk about here would be the hypereosinophilic adult onset asthmatics. This is a subset of patients with adult onset eosinophilic asthma. Now, what do I mean by eosinophilic asthma? Eosinophils are a type of white blood cell, a defensive cell that we all have and we all need. But they are inappropriately charged and radically upregulated in certain types of asthma, such as hypereosinophilic asthma. A sensitive test is a blood test where we see an elevated result of these. Other tests that we can do, which are advanced treatment center specific, are sputum eosinophil counts. There is a relatively good correlation between a blood test and a sputum test, so people do not need to be too concerned that they're not getting sputum analysis in respect to their severe asthma. These patients are usually requiring high-dose inhaled corticosteroid and are exacerbating requiring oral glucocorticoids to maintain control of their asthma. And they usually have severe evidence of air. Another group, and this is a really good example of why asthma phenotyping is a really good thing, is aspirin exacerbated respiratory disease. So what is aspirin exacerbated respiratory disease? It's also known as Samter's triad, which I will discuss later. Aspirin exacerbated respiratory disease is severe sinus disease in the form of nasal polyposis, the presence of asthma, and when a patient takes aspirin or a non-steroidal anti-inflammatory, such as ibuprofen or Advil, they have an exacerbation of their respiratory disease. The reason it's called respiratory disease and not asthma disease is because it essentially affects the lungs, the back of the throat, and the nose. So one did not want to get too specific correctly. There's also allergic bronchopulmonary mycoses. And people might remember this was referred to as ABPA, or allergic bronchopulmonary aspergillosis, and indeed an overreaction to the presence of aspergillus in the environment, which is ubiquitous fungi, is a misnomer because it is not just aspergillus which can cause this. Hence the terminology change to reflect this. And it's characterized by the presence of a very elevated immunoglobulin E, which is an antibody that we all make, but it's an antibody that is usually found in the presence of atopic diseases. It's also the presence of the specific immunoglobulin or an antibody to aspergillus, for example, in a positive skin prick test. And this can be a very debilitating asthma phenotype and a very severe allergic phenotype, and can require protracted high doses of oral prednisone and indeed antifungals, or indeed the newer biologics such as omalizumab or mepolizumab. And there's catamenial asthma, where asthma is worse in about 1 in 5 women around the time of their menses or their menstrual cycle. They're usually older in their menstrual cycle, have a higher BMI, and a longer duration of more severe asthma. Treatment add-ons, oral contraceptives, and indeed leukotriene receptor antagonists are effective in treating this. So I just want to actually move on and give you a bit more about neutrophilic asthma. This neutrophilic asthma, which is in cluster 5, we do see in our clinics, especially when we do sputum analysis. They tend to be a very refractory group of patients, albeit they make up a minority of severe asthmatic patients who are characterized by a lack of atopy and a high sputum neutrophil count. And they tend to be frequent exacerbators who are difficult to control on conventional medications. There has been a trial done called the AMAZES trial, which has used a commonly available antibiotic, a macrolide called azithromycin, as a prophylactic aid in the treatment of patients with severe refractory. And indeed, it seemed to show a benefit. In my own personal practice, in patients who fit this neutrophilic cohort, I will put them on azithromycin 3 times a week. Once I have ruled out hearing loss, an ECG to rule out something called long QT syndrome, and a sputum analysis to make sure they don't have a distant cousin of TB called Mycobacterium avium intercellular. And I must say, it's not, but it has been effective. There are also occupational asthma phenotypes, such as those who in their workplace are sensitized to certain haptens or proteins, such as bakers or hairdressers. There's irritant-induced, which is non-IgE mediated. And there's work-exacerbated. Now, there are slight differences between these. Work-sensitized and irritant-induced means the asthma only occurs in the workplace. Work-exacerbated is where a patient has asthma, but it's worse in their workplace. So why do we bother asthma phenotyping? I actually just wanted to give you a personal case that I actually came across myself. Joe was a 37-year-old male with no previous history of asthma. He had persistent rhinitis at the age of 30, watering rhinorrhea, using over-the-counter medications, antihistamines. He had the occasional cough and wheeze. He pretty much ignored these. And one day he developed sudden lower flank pain. So that's in your lower back at the back. Very debilitating, required him to present himself to the emergency department where he was diagnosed with having a trapped kidney stone, which is an excruciatingly painful phenomenon. So the emergency doctor correctly prescribed him diclofenac and said, make an appointment for the urologist to go see you. He presented the next day to the emergency department in extremis with severe shortness of breath and wheeze. It was really very bad. And he was admitted for 3 days. What had happened was that he actually had Samter's triad. So after he took the diclofenac, it exacerbated his underlying respiratory disease. It starts with this intractable nasal congestion and watery diarrhea. And it's very refractory to pharmacological treatment, and it's progressive. Tests such as an IgE are usually negative. A total or near normal CT of your sinuses or the absence of nasal polyps effectively means you don't have this. But where you have nasal polyps and asthma, it is always a question I ask in my outpatient clinic. And these individuals actually suffer sudden severe attacks within 20 minutes to 24 hours, requiring emergency visits, admissions, and potential intubations due to the severity of these exacerbations. So it's really important to actually find out who these patients are and identify them. And it's felt that in severe asthma outpatient clinics, 8 to 12% of people have Samter's triad, and it is a distinct phenotype. And just to go through this really complicated pathway, and this is not trying to put you off, essentially if you have 2 buckets of water and 1 tap flowing into each bucket, and you have a split hose, 1 bucket is mixing with a substance which is going to be very, very inflammatory. Another bucket is going to be anti-inflammatory. When you take an NSAID or aspirin, you cut off the supply to the anti-inflammatory bucket. So all the water flows into the pro-inflammatory bucket and causes lots and lots and lots of inflammation. And that's what happens when these patients take aspirin or an NSAID. There is a very good treatment for it. There was a really good review article in the New England Journal of Medicine in the last 2 or 3 months, which talked about this aspirin exacerbated asthma. And indeed, in Scripps Hospital in San Diego, they have done 1,600 aspirin challenges where they give people with this incremental doses of aspirin. And it is very effective in managing their asthma treatments. So who would have thought that people without or with this particular phenotype respond to daily aspirin? Hence, it underlies the importance of phenotyping this disease. And again, it is just really important to say one shoe does not fit all asthmatics. And we need to move away from this paradigm. And we have made considerable progress in identifying asthma. And this is why I wanted to talk about this thing called T2 inflammation without getting too complicated about it, because it is a complicated field. So when we talk about T2, we're talking about a signature that a bunch of different immune cells have in response to certain cellular proteins. So T2 inflammation is mediated by cells like eosinophils, mast cells, basophils, T2 helper lymphocytes, ILC2s, and IgE producing B cells. Now, what the heck does all that mean? What it means is that these are a bunch of immune cells that are programmed to respond in a heightened sense to a certain type of cellular protein. Some of these patients exhibit very high levels of these proteins and these activated cells, so-called T2 high asthmatic patients. And other asthmatic patients, when we look at them, exhibit little or no evidence of this T2 high inflammation. So there's something else driving their asthma. So trying to target their eosinophils or mast cells or basophils may well be futile. This division of asthma phenotypes based on biomarking is becoming increasingly important. And one of the reasons actually it's becoming increasingly important is nearly leaving aside, if I may, at my peril, is from a healthcare provider perspective in terms of cost. For example, if you were to group 1,000 severe asthmatic patients together and split them in two and put 500 of them on omalizumab and the other group on a placebo, you would probably see any effect between the two groups. However, if you characterized severe asthmatic groups in terms of atopy and an immunoglobulin level and stratify them in that effect, you would absolutely see a very beneficial effect from omalizumab. When the newer biological medications were launched, the prototype of the anti-IL-5s being mepolizumab, which targets, as I said, interleukin-5, which is a cellular protein. So think of it as a text message that fires down to early cells in your bone marrow and tells them to become eosinophils and go up to the airway. The initial studies were failures because they didn't stratify patients according to their blood eosinophil count. Once they did that, they saw very relevant, meaningful messages in regard to the treatment of it and stratifying it. So it's really important that we do this. A, that we do the patient a benefit and we don't sign someone up for 6 to 12 months of a treatment that we know won't work. And B, we do the payers the benefit of the doubt by actually affecting a costly medication to the right patient. For example, in cancer, unfortunately, if you've lung cancer, the biopsy will be sent for certain stains. One of them includes a PD-1 inhibitor stain. If you are low in expressing this particular marker, you don't get a medication. And if you're high, you get this medication. This medication has a price tag of about $200,000 a year. We know it absolutely does not work in people with low expression of this particular marker. So why would you give it to these patients? The same thing applies to asthma. And the same thing applies to our patients. Don't waste their time with a medication that won't work. Move them on to something that will. The other issue is that the international guidelines, thankfully, are coming in behind people like myself who do severe asthma clinics to say, yes, you got to start looking at sputum counts and blood counts and eosinophil counts and atopy to really try and stratify these patients to see who's going to respond to one treatment or the other. So you don't waste patients' time, because it can take up to a year to see a response from these latest biological therapies. This is a really good graph that was done by Sally Wenzel in 2013. Sally Wenzel is a guru of asthma. She's absolutely fantastic. Even this has become slightly updated, and this is how fast the field is moving. So, for example, sorry, Heather, that's probably my voice. So the H here has been dropped as opposed to a T, referring just to a lymphocyte. It's referring now to a group of cells, hence it's T2. But essentially in asthma, and this is kind of in regards to clinical treatment where we overlap with research, we treat T2 high patients, and they are different from T2 low patients. T2 low patients, these are the non-atopic, non-eosinophilic patients. It's usually, as I said, late onset, females, postmenopausal. Obesity, absolutely huge role. Smoking-associated neutrophilic asthma. It'll be interesting to see with the advent of marijuana legalization how that affects our asthma population. Indeed, it's wise to also mention, in the interests of open transparency and essentially honesty, is that trials have been conducted in the 1970s of tetrahydrocannabinol, as there are THC receptors on epithelial cells in our bronchial membranes, of using it to see whether it was a broncho relaxer. So I do have patients who indeed tell me they feel better when they smoke a joint. But whether that's because they're suffering or benefiting from the effects of cannabis or it's airway modulation or not remains to be seen. But going forward, it's going to be an interesting population to see what happens here. There's also smooth muscle-mediated, what we call polygranulocytic asthma. So you only know that someone has this by doing bronchial biopsies, which is something we don't conduct very often in people with asthma, but it's something I'm doing more often. I've had patients who have been poorly responsive to mepolizumab, for example, who I have done bronchoscopies for, who have very low blood eosinophil counts after treatment and very low sputum eosinophil counts after treatment, 6 months into treatment, where they were very high prior to treatment, who I do bronchial biopsies on. And the pathologist says, hey, their bronchial mucosa was full of eosinophils. So there's something else going on here. And this brings forward, for example, a seminal piece of work which was done by Stephen Smith at McMaster University, where he recognized that there was localized airway eosinophilipoiesis, which was mediated by what we call airway alarmins. Now, what are airway alarmins? Airway alarmins are essentially a bunch of proteins or cytokines or cellular messengers that when you inhale something, your airways say, hey, you've just inhaled some bacteria. We need to tell the immune system that you've just inhaled bacteria. So these alarmins are released to the basal laminal area where they get into the bloodstream and they tell the body that there's a problem here. And immune cells are recruited to this spot. And he recognized that these were actually also responsive for the driving of localized eosinophil activation and proliferation, which is a very interesting finding, which does potentially suggest that some patients who are partially responsive to these fantastic medications such as mepolizumab may indeed have a localized producer which is causing their eosinophil and driving their eosinophil count, which isn't being tackled by these anti-IL-5 treatments. Please don't find this slide complicated. I find it very complicated. It was just a quick refresher when we talk about Th or T1, T2 types of cells. When a T cell, which is a lymphocyte, a particular type of lymphocyte, arrives, it's totally naive. It doesn't know which way to go, left, right, etc. It doesn't know what type of cell to next mature into you. It depends on what the cocktail of cellular environmental proteins are present will direct it to go one direction or another. And we know that in the presence of allergy and asthma, the cellular cocktail will drive a naive T cell to become a Th2 producing cell. And it will then produce these guys here, interleukin 4, 5, 13, 25, amphiregulin, and 10. 4, 5, 13, 25, amphiregulin. We absolutely categorically know that these are drivers of asthma. For example, interleukin 5 drives eosinophils to be produced at a very high level in our bone marrow, to migrate up to our airways, to release all their pro-inflammatory membranes and cellular proteins, and live long. Interleukin 13 tells bronchial smooth muscle to get bigger and be hyper twitchy. Interleukin 4 does the same thing, and they both tell goblet cells to start producing, which are little cells, or the lining of our bronchi, produce lots of mucus, which causes that cough. So that's where we hang out here. Currently, all the large players in regards of our biological treatment target these guys here. But there are people who think that there exists a Th17 high asthma phenotype. There have been some clinical trials which have looked at this and tried to treat this area, but unfortunately were unsuccessful. So again, it's just reinforcing how complicated this is, but how necessary it is to focus in on identifying select asthma phenotypes, so we can tell Johnny he's going to respond to a certain treatment or he's not. So what tests do we do to try and phenotype? So we do physiological testing, spirometry, pre and post SABA. It's essential that you go pre and post. I always ask for pre and post. What you want to see is reversibility. You want to see a bounce in their FEV1, FEC ratio. So you want to, I did 2 years of research and I was used as a guinea pig. And no matter how much fentanyl was thrown at my airways, they never changed more than about 2%. And on a significant majority of people with asthma, they'll bounce up more than 1% or 200 milliliters, which is a diagnostic criteria. Some of them don't because they've got fixed airflow obstruction because of long-standing asthma. We also want to look at static lung volumes and DLCO. A DLCO is how good your blood and lungs are at extracting oxygen from the air. A methacholine challenge is a very good way of ruling out asthma. Again, these are all pieces of the jigsaw. There's no one diagnostic test. No one diagnostic test which will tell you have or don't have asthma. Eucapnic hyperventilation is for people with exercise-induced bronchoconstriction, and then fiber optic laryngoscopy for patients who have a query of what we call vocal cord dysfunction. We do blood tests looking for eosinophil numbers, an ANCA looking for asthma mimics, which are a vasculitic disease, a very severe form of asthma called Churg-Strauss, or EGPA. Alpha-1 antitrypsin deficiency, a very rare thing which can cause COPD, but can be an asthma mimic. Certain fungi reactions, skin prick testing. We also do imaging. So we want to look at chest x-rays. So here's a normal chest x-ray. Here's a chest x-ray which has infiltrates of a patient of mine who had actually something called Churg-Strauss or EGPA and was being labeled incorrectly as asthma. Another condition, which is ABPA or ABPM, as we mentioned. This is a normal CT scan. This is normal lung tissue. This is bronchiectasis, where a patient has holes in their airways. And we need to identify these patients. Skin prick testing. And then we go on, we just move on to the therapies, which I've mentioned earlier on, which are looking at things like Xolair, which reduces exacerbations, improves quality of life. So again, these slides will be available to you. This new one, which I mentioned, mepolizumab, which targets interleukin-5, which has worked fantastically in properly identified patients. And this slide, and I'll kind of leave things here, guys. This slide here is really just identifying how complicated it is, but what we're trying to target. And if I move on a couple of slides, I left this one in because it is like Chinese. What we're trying to do here is we're trying to block pathways. But if we can get early into the asthma pathogenesis, like up here, we can block all this stuff from happening. And that's really the golden grail of asthma. I'd like to thank you and attention, apologize for my raspy voice, and I'd be delighted to take as many questions as I can answer. Thank you very much, and thank you to Asthma Canada.
Thank you so much, Dr. Mitchell. That was very informative, and you took a very complicated topic and really explained it well for all of us. Really appreciate that, especially as you're recovering from a cold. Now, the chat box is open. If anyone has any questions, please do type them in so Dr. Mitchell can address them. Again, the chat box is to the left of the screen. We do have a question here. How accurate is phenotype testing? Dr. Mitchell, you're muted if you are speaking.
Apologies. How accurate is asthma phenotype testing? It is fair. It's in severe asthma. It's actually very accurate. I can pretty much have a sputum analysis, blood testing, skin prick testing, radiological imaging to rule out mimics of severe asthma, and tell a patient with about a 70 to 80% confident interval that I will guarantee you a positive response to this treatment, such as mepolizumab. So it is very accurate. It's also part of the criteria in order to actually prescribe some of the advanced biological medications. So, for example, several of the health insurers, and indeed the guidelines from the companies who produce these themselves, will dictate that you need to have an elevated blood eosinophil count before you'll be considered for any of these medications, such as the anti-IL-5s.
Just to add to that, you'd mentioned early on that in a lot of cases, or in some cases, there are no biomarkers such as elevated eosinophils and blood cells for people that have severe asthma. Is that an issue with accessing these biologic medications?
It absolutely is. So, for example, if you have a very low blood eosinophil count, you will not qualify for any of the available anti-IL-5 therapies.
I see.
The difficulty with this is there potentially are patients who, as I mentioned, have localized eosinophilic within their airways who may well benefit from this and are excluded as a result of the blood trial. The problem is that when, for example, GSK did their initial studies in mepolizumab, they failed. They didn't meet their clinical endpoints when they just gathered up a load of people with severe asthma. But when they stratified it as per eosinophil count, they saw radical differences between those with elevated eosinophil counts and those with not. So hence it became part of the criteria. And I do understand that because it's a very expensive medication, and also you need to be on it for 6 to 12 months. If someone has severe asthma and you know it's not going to work and there may be something else for them, it's probably not an appropriate thing to do to try them on it for 12 months and then say, hey, let's move on to the next thing.
Right. Great, thanks for that. We have quite a few more questions, so I will move ahead. Are phenotypes fluid? Can you start in one and then move towards another?
I don't know. And I say that with open disclosure. We don't know whether people become less atopic or do they stay the same. We do know with young people who are atopic and with mild asthma tend to actually grow out of it. But we actually can't tell. The only predictor of someone who, for example, will evolve out of asthma as a young adult is the mildness of their symptoms. The more severe asthma you have, the more likely you are to maintain it into adulthood. The milder your asthma, the more likely you are to give it up or to grow out of it, for want of a better word. But we don't know whether one asthma phenotype evolves into another, such as a high IgE skin prick test positive to cat becomes a neutrophilic asthma over time. I would say not, though.
Okay, thank you for that. How much of any research is done on humidity and airway reactivity, that is exercise-induced mouth breathing bypassing the nose?
Really good question. A good bit, actually. We do something called eucapnic hypoventilation challenges on people who we think have exercise-induced bronchoconstriction or exercise-induced asthma. So why do we do this? So about 27% of people who have exercise-induced asthma will do a methacholine challenge, and the methacholine challenge, which is actually a really good test, will tell us that they don't have a trace of asthma. Yet when they exercise, they do when they drop their FEV1. And it's actually felt to relate to breathing in not so much humidified air, but actually dry air. And when you breathe in, so eucapnic means it's the same percentage of carbon dioxide, and we get them to exercise, and then we do their lung function testing the same way as you would when you're doing spirometry or when you're doing a methacholine challenge. And we do it every 5 minutes for half an hour. And 27% of people who have a negative methacholine, who smell like they're going to have exercise-induced asthma, do indeed have exercise-induced asthma. So we do take things like dry air or wet air very seriously. So I went from doing my fellowship in Ontario, which is wet and very humid, to Calgary, which is as dry as a bone. And honestly, I see people who have moved here who had asthma in Ontario and it's gone here. Or I see people who had very mild asthma in Ontario who move here and it's worse here. So obviously there's different types of people who respond to different types of humidity levels.
Great. Next question. Would targeting cytokines higher in the cascade cause more adverse events, especially since they may block more pathways further down the line?
That's a really good question. So I'll give you an example of that. GS-CMF, so granulocyte stimulating Connolly macrophage formation. It's essentially something that you see big in people who've got hematological malignancies, where they're given chemotherapy and they get quite anemic, and they're given this, which stimulates their bone marrow to produce a ton of blood cells. That GM-CSF is actually really responsive or pivotal to producing eosinophils in the airways. So why not target that? Well, the big fear is that there's a condition called primary proteinaceous alveolar or primary alveolar proteinosis, which is where you fill up with gunk in your lungs. And the reason why you get that is because you actually have an autoantibody which targets GM-CSF. So introducing a monoclonal antibody which would target that might be counterintuitive. And you're right, with all these things, I mean, they do so many things. We don't know. And that's why we do clinical trials. So one of the ones that we're doing at the moment is an anti-TSLP monoclonal antibody. So TSLP stands for thymic stromal lipopoietin. And it's felt to be kind of not here, but kind of here as an up marker or an upstream cytokine regulating the asthmatic response. And there have been a couple of, fairly good clinical trials, and thankfully the safety profile in that has been good. But you're right, we don't know, which is why we do these clinical trials. So, for example, there was the FDA managed or mandated the makers of Xolair, omalizumab, to do cancer studies on Xolair, because it was felt that there might have been an increased risk of cancer studies. And there's not, actually, as it turns out. But there was still a small little signal in some of the trials that they did. And as a researcher said, we simply can't say whether or not blocking immunoglobulin E has absolutely no neoplastic purposes. So this is why we do clinical trials, and this is why we do. And pharma is very involved in this stage 4 and post hoc real world analysis to make sure these signals aren't coming through.
Great. Next question. Will biologic drugs for asthma stop working? If so, on average, how long do they work? And what's next if the biologic drug stops working?
So that's a very good question. I suppose the first thing to say is that a biologic is different from an antibiotic in respects that when an antibiotic is given to a bacteria, the bacteria learns through lots of different, very, very clever evolutionary tools to outwit the way the antibiotic is killing it. Or it shares information with another bacteria, and by that learns to outwit how the antibiotic is killing it. Biologics are slightly different in that the cytokine that you're targeting, or the receptor that you're targeting, doesn't really have that same kind of biological hardware inbuilt in it to try and outwit the biologic. The small fear is that you may develop an immune response. So if you think about it, the same way as you get a vaccine, when you get a vaccine, you get a peptide which looks similar to the flu virus injected into you, and your immune system says, hey, that's bad. Let's produce a lot of similar antibodies so the next time we see it, we can kill it off quickly. Why does that not happen with biologics? Well, because biologics have been developed to kind of outwit that, or essentially like a Klingon warship, to cloak themselves from an immune response. But there is, in some people, a small immune response. And whether or not that comes to play through in years down the line, we don't know. That hasn't been the case with omalizumab, to be honest with you, to date. And indeed, 2 studies, a French study and a Polish study, have shown that when you take people off after 3 and 6 years omalizumab, about 70 and 50% of people need to go back on it within a year, respective to those 2 studies that I mentioned, but that the response was absolutely the same. So it would appear to date that the response is sustained. What should be mentioned, though, is actually, and I kind of mentioned it earlier on in the study, is person perception. So I have a few patients who've been on mepolizumab for 18 months or 24 months who've done really well, and they're now starting to say, hey, doc, I'm not doing so well anymore. And I don't know whether it's the drug not working as well as it did, or whether it's their perceptions have changed. So these were people who were really debilitated, and one of them has gone back to the gym and he's jogging. He's 55 years of age, and his complaint, and it was a great complaint to have, was that he's getting really breathless when he's hitting 15 kilometers on the track. He said, you couldn't get up the stairs 18 months ago. But his perception of where he should be had changed potentially. So I don't know whether that's an influential factor or not.
Well, that's really interesting. Thanks for sharing that story. I think we have time for just one more question, and that is, how can one differentiate COPD in the 5th phenotype group with severe symptoms and maybe no significant change post-bronchodilator?
Oh, God, I tell you, you'd probably win a Nobel Prize if you figured that one out. that's what we're all talking about at the moment, is this asthma COPD overlap. It does actually, in the recent GINA guideline updates, it gets mentioned actually. Some people suggest that a history of asthma, considerable bronchodilation post-drug, so when you give them Ventolin and you do spirometry on them, if they have a big bump up in their FEV1, FVC ratio, in the presence of a high blood eosinophil, you have an asthma COPD overlap. Where this is actually in the real world really important is more for the COPD population in respect of whether or not you continue an inhaled corticosteroid. The reason why the inhaled corticosteroid is obviously it's a backbone in treatment in asthma, but the recent guidelines have said that as a second stage in COPD, you should be giving it. You should be giving a LABA and a LAMA combination and then adding it in afterwards. So it's really important there. But distinguishing it really is very difficult, to be perfectly honest with you, and there's no real answer to that.
Thank you so much. We are at the end of our time. Dr. Patrick Mitchell, that was fascinating. And I'm sure all the attendees would agree, since there are many more questions that we haven't been able to get to. Sorry about that. We really appreciate you taking the time to give this presentation, and thank you to everyone for attending. If you have benefited from our webinar series and would like to see similar programming, please consider making a donation at www.asthma.ca/donate. And if you have any further questions, please send us an email at info@asthma.ca and we'll be happy to help. Just a note, this webinar recording will be made available on our website and YouTube channels. Thank you again, and hope to see you for our next webinar, which is coming up in November. Thank you and have a lovely rest of the week.
Thank you very much.